One of the most famous quotes of Mark Twain goes something like, "Age is an issue of mind over matter. If you don't mind, it doesn't matter." However, without reference to the contents in which this saying was constituted, or Mark Twain's frame of thinking then, I am here to tell you what you might already know as a medical student. Age and aging does matter in pharmacology, even if you don't mind age. Peace and light. My name is Dr. Sonia Fulgham, and today I will be presenting about the approaches of managing depression and pharmacology with elderly patients effectively. Age has been described as the progressive accumulation of more or less random changes. But apart from the decline in the fine looks and the cosmetic enticing features, what really changes when you are no longer young that warrants our attention as medical prescribers, number one, is the cardiac function and structures in older adults is different from that of young adults, with such traits as reduced elasticity and compliance of the great arteries and aortas. Effective, this reduces the myocardial relaxation rate while increasing systolic arterial pressure. Impedance to the left ventricular ejection and interstitial fibrosis and left ventricle hypertrophy is the ultimate. Other effective traits include sinoatrial noid conduction time and intrinsic heart rate. Second, aging results in decreased renal mass, which is a reflection of reduced nephrons. Age-related changes also include water and salt regulations, as well as inconsistent non-uniform decline in glomerular filtration rates and renal plasma flow. Aging results in changes within the stomach and duodenum, small intestines, colon, pancreas, and liver, for example. Progressive decline in liver blood flow and liver volume is notable in geriatric patients. Pancreatic changes include dramatic reduction in the secretion of major enzymes like trypsin and lipase. The altered function of the hypothalamic pituitary adrenal axis, or the HPA axis, affects neuroendocrine responses to both physical and psychosocial stress. Age is one of the most important considerations for all prescribing medical practitioners. This is mainly due to the variations in how the drugs move in and out of the body, or simple pharmacokinetics, as well as the effects of drugs and their mechanisms of actions on the body, which is also known as pharmacodynamics. Let's first take a look at pharmacokinetics and its elements. Drug absorptions. See, now there's a conflicting evidence about how aging impacts on drug absorptions, possibly due to the variations in the methods employed to assess age-related drug absorptions. Notwithstanding, some of the earlier studies reported significant age-related changes, including reduce in gastric emptying, secretion of gastric acid, and the small intestine's absorptive capacity, and splenetic blood flow. On mechanisms and bioavailability, aging has been linked to the reduced first-pass metabolism, perhaps because of the reduced blood flow and liver mass, which were mentioned in the previous slide. This impact on the bioavailability of drugs that undergo extensive first-pass metabolisms like labetalol and propranolol, drug distribution, and especially that of water-soluble polar drugs tend to have smaller distribution values in older people. This leads to higher serum levels in the elderly. The other important element in pharmacology with respect to age has to do with drug clearance. As you may already know, this implicates the renal and liver functions, which we already have seen in the previous slides, have reduced functionality due to age. There is evidence that reduced renal functions, for example, could affect both renally excreted drugs and those that undergo extensive metabolisms within the liver. Now, with geriatric pharmacodynamics, focus is on therapeutic effects, toxicity, and the adverse reactions of effects. Under these three aspects, various differences in pharmacodynamics are notable between the young and the elderly. Let me explain how. Drug therapeutic effects. When one gets older, their sensitivity to drug tends to increase than when they were younger. This is because pharmacodynamics is highly dependent on drug concentration at the receptors. The receptors is response. The post-receptor occurrences in cells and homeostasis mechanisms. Aging may affect all those pharmacodynamic factors, resulting in increased sensitivity to drugs. Concerning toxicity, the decline in organ functionality, which implicates drug metabolism and neurochemical alterations in the central nervous system, resulting in a blood-brain barrier that is less effective, could expose the elderly to high drug levels and potential toxicity than when they were younger. The increased risk of adverse reactions in elderly patients compared to younger ones can be traced to such issues as variations in plasma concentration. Changes in pharmacokinetics in the elderly implicate the sustainability of older patients to both adverse reactions and toxicity. So now that we understand the implementations of aging and pharmacokinetics and pharmacodynamics, we are in a better place to understand how pharmacological treatments of geriatric depression, which is the most common mental health problem in elderly, which is approached. So in the next 4 slides, we shall focus on following categories of drugs, their efficacy, potential adverse effects when used to treat geriatric depression. Selective serotonin reuptake inhibitors, SSRIs. Selective norepinephrine reuptake inhibitors, SNRIs. Tricyclic antidepressant, TCAs, and monoamine oxidase inhibitors, MAOIs. So, selective serotonin reuptake inhibitors like citalopram, sertraline, and escitalopram are considered the first-line treatments for geriatric depression. This is the first of all because research in geriatric depression provides adequate evidence to support their treatment efficacy. Secondly, most elderly patients tend to demonstrate high drug tolerance when taking SSRIs. This is because SSRIs have lower anticholinergic effects compared to other antidepressants. On the downside, SSRIs could cause such side effects as nausea, somnolence, insomnia, dry mouth, agitation, and possible hypoatremia due to reduced renal functioning caused by aging. The SSRIs fluoxetine and paroxetine are generally not recommended for elderly patients. Fluoxetine is usually associated with long half-life and prolonged side effects, while paroxetine has the greatest antinergic effects amongst all SSRIs. And so here are some pointers concerning selective norepinephrine reuptake inhibitors. SNRIs like duloxetine and venlafaxine, and evidence available shows that they are competitively considered the first line together with SNRIs for treatments of geriatric depression due to their efficacy. SNRIs have been described as having a low potential for pharmacodynamics and interactions due to their weak to moderate inhibition of CYP isoenzymes and the enzyme CYP2D6. Although SNRIs are well tolerated by elderly patients, some of their potential side effects include gastrointestinal distress and sedation or drowsiness. Now, tricycline antidepressants have demonstrated a level of efficacy, especially in younger patients. However, when it comes to the use in geriatric depression, take note, they are primarily used as antidepressants, and several guidelines do not recommend the use of tricycline antidepressants in elderly patients. In fact, they have been considered as potentially inappropriate medications for elderly patients, disease notwithstanding. You ask, but why? TCAs have been linked to inhibiting the actions of acetylcholine neurotransmitter by impeding the transmission of parasympathetic nerve impulses. In turn, this leads to reduction in involuntary movement or spasms of smooth muscles such as those in the bladder. This is what is known as the anticholinergic effect. Already and without depression of medication, old age often leads to impairment of cognitive impairment. TCAs like dispramine and nortriptyline have been shown to have the potential to affect the cognitive impairment in the forms of the speed of information processing and executive skills. TCAs may also affect the elderly patient in the cardiovascular system. Now, there has been significant decline in the use of monoamine oxidase inhibitors for treating depression, mainly due to their tendency to cause often fatal adverse reactions, especially in elderly patients. Here are some points to note about the use of MAOIs. Some, such as phenolazine, are effective and safe in older patients. It is possible to achieve a full therapeutic response in 5 to 7 weeks of treatment. And here are some potential adverse reactions that are associated with the use of MAOIs in geriatric depression: hypotension, hypertension, and food interactions. While thanking you so very much for your active engagement during the entire presentation, let me share with you 3 key issues raised about elderly and the treatment of geriatric depression. 1. Aging causes significant changes in the pharmacodynamics and pharmacokinetics of people, and this means that the pharmacodynamic and pharmacokinetics of geriatric populations differ from those of the younger population. Due to their high tolerability, superior efficacy, and comparatively fewer and less fatal likelihood for causing adverse events, SSRIs and SNRIs are the preferred pharmacologic treatment option for the geriatric patient with depression. Owing to their tendency to trigger significant adverse reactions in the elderly include fatal ones, tricycline antidepressants and monoamine oxidation inhibitors are not recommended for the treatment of geriatric depression. So, here are some sources that you can look into for further information related to the treatment of geriatric depression, as summarized in the presentation. Peace and light, and thank you, and have an amazing day on purpose.